Good evening, everyone. I'm Dr. ANUSHA AJWANI, Vice Chairperson and Consultant at AJWANI Eye Hospital, Bhopal. Thank you for giving me the opportunity. And today I'll be speaking about polypoidal choroidal vasculopathy, its classification and non-ICGA diagnostic criteria. So PCV is a subtype of neovascular AMD characterized by nodular dilatations arising from the neovascular network that ramify mainly in the sub-RP space and which are best seen on ICGA. So coming to the basic characteristics of PCV, on fundus evaluation there is presence of orange-red lesions found at the posterior pole of retina. On fluorescein angiography there is dye leakage which occurs from the lesions, and on ICGA there is presence of distinct polypoidal lesions. Characteristics of active PCV include clinical, OCT or angiographic evidence of any one of the following, that is vision loss of more than 5 letters, subretinal fluid with or without intraretinal fluid, pigment epithelial detachment, fluorescence leakage and subretinal hemorrhage. So PCV roundtable meeting panel of experts in Singapore 2010 suggested an angiographic definition for the same, which states the presence of single or multiple focal nodular areas of hyperfluorescence arising from the choroidal circulation within the first 6 minutes after injection of ICG with or without an associated choroidal interconnecting vascular network. Presence of orange-red subretinal nodules with corresponding ICG hyperfluorescence is pathognomic of PCV. Coming to the pathogenesis, it is not clearly understood. However, there is propensity of choroidal vasculature for dilation and aneurysmal formation. Coming to the classification, the Japanese study group of PCV in 2005 suggested the classification of PCV, according to which in quiescent PCV there is presence of polyps in the absence of subretinal or intraretinal fluid or hemorrhage, exudative PCV in which there is exudation without hemorrhage, retinal thickening, PED, subretinal lipid exudation, and hemorrhagic PCV in which there is hemorrhage with or without other exudative characteristics. On the basis of size, with involvement of outer choroidal vessels, it results in larger lesions which are easily diagnosed on biomicroscopy, and involvement of middle choroidal vessels results in smaller lesions diagnosed on angiography. Based on number or arrangement, it can be solitary, arbitrarily defined as 1 or 2 polyps, or multiple, which can be arranged in the form of a ring or cluster. Based on location, it can be peripapillary, in which more than half of the lesion is located within 1500 microns of disc margin, macular, in which more than half of the lesion is within 6000 microns of center of foveal avascular zone, excluding the peripapillary zone, extramacular, in which more than half of the lesion is located outside the above two mentioned zones, and multi-location, in which the lesion straddles all over the 3 regions, with none of them containing more than half of the lesion, or if there is more than one contiguous lesion. Coming to the updated nomenclature, an updated consensus nomenclature and non-ICGA diagnostic criteria has been recommended by APOIS PCV work group in August 2020. So according to this, here an international panel proposed and validated a diagnostic set based on combination of OCT signs and color fundus photographs, which can differentiate PCV from typical neovascular AMD without relying on ICGA. The propositions included, the work group reviewed clinical and imaging observations related to the 2 key components recognized in PCV complex, often referred to as polyp and branching vascular network. With additional information gained from ICGA, OCT and histology, panel consensus is that PCV is a variant of type 1 neovascularization within the AMD spectrum. The terms polypoidal lesion and branching neovascular network are recommended rather than polyp and branching vascular network to describe the 2 lesion components within the PCV complex. Coming to the 9 non-ICGA features evaluated for a predictive value of PCV diagnosis, of which 6 are based on cross-sectional OCT, 2 are based on color fundus photograph or fundus evaluation, and 1 is based on end-phase OCT. So coming to the OCT features, there is presence of a sharp-peaked PED, which is narrow-peaked PED with an inverted V configuration, also described as a thumb-like protrusion. There is a sharp vertical incline more than 70 degrees on at least one side. Sub-RP ring-like lesion in which a round structure is seen under the PED and it may have hyporeflective center and hyperreflective outline. Complex or multilobular PED in which there is a notch in PED resembling an M. Double layer sign, thick choroid with dilated halar layer vessels, presence of a fluid compartment which is predominantly SRF with or without mild IRF, end-face OCT features including complex RP elevation in which hyperreflective branching vascular network connecting multiple PEDs is seen. Now coming to the fundus features, there is presence of extensive subretinal hemorrhage and presence of one or more orange subretinal round elevations. A combination of three major criteria achieved an area under the curve of 0.90, and that is sharp peaked PED on cross-sectional OCT, sub-RP ring-like structure on cross-sectional OCT, and complex RP elevation on end-face OCT. This set of criteria serves the need for most clinical situations, allowing for a quick, practical, and non-invasive method for differentiating PCV from typical neovascular AMD, especially in clinical settings that do not have access to ICGA. Thank you.
Comments from your side?
No, I am aware of this classification, Anusha. This has come in August issue of IG also, I think.
Yes,
And that's a very illuminating because the relevance of this classification is further enhanced by because a lot of people may not have access to ICGA and hence the relevance, and because the concordance is pretty high, as you said, area under the curve for at least sharp peak PED, and there are major and minor criteria
Yes, sir.
listed here.
The three major ones are that sharp peak PED and confluent ones.
So people should not rely that ICGA has to be mandatory there.
Yes, sir.
There are a lot of other things which have been said in this article.
Yes, sir, but I could not finish everything in this.
I think you should refer to that article, and people can read that article when so.
Definitely, sir.
But suffice to say that it's important for clinicians to recognize this entity
That's true.
because it's frequently misdiagnosed as ARMD.
ARMD
by
only,
a
yes.
lot of people, and because the management may differ. What
Definitely,
I personally
sir.
feel is you see drug of choice is today aflibercept
Yes, sir.
monotherapy and not bevacizumab or not ranibizumab because
Yes,
the
sir.
results are not as great.
That's true.
So that has to be that also has been emphasized in this.
Yes, sir.
And brolucimab, which is a newer kid on the block, also may have a role in specifically in these entities, provided they are resistant to aflibercept.
Yes, sir.
Because PDT is no longer available.
Yes.
And therefore, all this average study, blended study, they have come to conclusion that aflibercept monotherapy is nearly as good as PDT or the combo therapy.
Yes, sir.
So, thanks, Anusha.
Thank you so much, sir.